So this is going to be our presentation for our toxicology chapter. It's going to be brief. I'll be reading some slides, maybe expanding on a few things, but there's not a lot of information I can give you that you won't find actually in the PowerPoint or the notes section. So I advise you to really spend some time reviewing that. We'll skip through our competencies and move directly to our introduction. So of course we know that every day we potentially come in contact with poisonous things, but things we might not know is that 2 million people a year are actually affected by acute poisoning, but chronic poisoning is more common. And death by poisonings, even though we might not think so, are actually fairly rare. Poisonings in children have decreased steadily since the 60s because of child-resistant caps on medications. It's harder to get into grandma or mom or dad's pills, even though they may look like candy. Whereas death by chronic poisoning in adults has actually increased because of increased drug abuse from everything from opiates to, well, I know there's an opiate epidemic going on, lots of different street drugs and things that are used off label. So we'll talk about some definitions. Definition of toxicology is the study of toxic or poisonous substances, and a poison is any substance whose chemical action can actually damage body structures or impair bodily function. A toxin is a poisonous substance produced by bacteria, animals, or plants. So you'll need to know the definition of that. You may see it again. And substance abuse is the misuse of any substance to produce a desired effect. Basically, anything that is used, you'll see warning labels on all kinds of things from paint cans to household cleaners that say misuse of this product in any way other than its intended use is illegal. And overdose is the toxic dose of any drug. So when dealing with poisoning patients, your primary responsibility is to recognize, obviously, that poisoning has occurred by paying attention to your surroundings and realize that very small amounts of some poisons can cause considerable damage. So make sure that whole scene safety thing that we do at the beginning of of every scenario we run, and that's going to carry out into the calls you run in the field. Make sure that you pay extra special care to that because you don't want to become a patient as well. And also know that signs and symptoms of a poisoning would obviously vary according to what that specific agent was and how it affected the body. Here's a chart of some common agents and actually the signs and symptoms associated with them. We have opiates and opioids that we're familiar with, things like morphine, fentanyl, oxycodone, and we're talking about lowered respiratory drive or respiratory arrest, the pinpoint pupils, coma, being completely unresponsive, or if they're in an advanced state of shock, maybe some hypotension to go along with that. Sympathomimetics are drugs that actually mimic the sympathetic nervous system, and these are things like cocaine and methamphetamines. And you see hypertension, tachycardia, that goes along. You have arrhythmias in many cases in chest pain that are associated with that. Dilated pupils, because remember it's mimicking the sympathetic nervous system, which is a release of adrenaline. They may be agitated or combative, and they may actually have an increased body temperature. Sedative hypnotics such as diazepam, Valium, midazolam, Versed, things like that, where they can mimic intoxication by alcohol with slurred speech, but they can also fall into the opiate category with some hypoventilation, the low blood pressure, and obviously with their sedative properties, they could lead to a patient being unresponsive. Anticholinergics. Anticholinergics are things that are cholinergic being acetylcholine being affiliated with the parasympathetic nervous system. So anything an anticholinergic does is against the parasympathetic nervous system. Parasympathetic nervous system slows things down. So anticholinergics, if they are against the parasympathetic, will speed things up. So you might get the symptoms mixed up with things that mimic the sympathetic nervous system, because something that blocks the parasympathetic would have a very similar response. And these could be, once again, the tachycardia, the hyperthermia, You could have high blood pressure or dilated pupils, dry skin, and all the way to, you could lead to sedation, delirium, and decreased bowel sounds, which in an emergent situation wouldn't be something we would really concern ourselves with. And last but not least, the cholinergics, which are the organophosphates and things, nerve gases that we talk about. These are pesticides as well. We use the acronym SLUDGE for salivation, lacrimation, urination, defecation, drooling, diarrhea, some gastric upset and cramps, emesis, which is also which we know is vomiting, and then muscle twitching, or meiosis, which is pinpoint pupils. And there are specific treatments for these as well that you will be able to administer as an EMT. So if your patient's conscious and you're able to ask them questions, or you're able to ask family members, bystanders, whatever, we'd like to know what the substance is and how long ago it was taken, how much was taken, was there anything to eat or drink before or after? We want to know that, because what if it's a caustic substance? Obviously, we would have concern about airway burns or a patient possibly vomiting, and then once again burning their airway as they were to produce that emesis. And is there any antidote or anything that's been given? And this could be anything from a prescribed antidote to home remedy. And then again, how much does the patient weigh? Because if we can determine how much of a substance was ingested, we can maybe, once we pass that information on, we can find out at the hospital how much damage it'll do. Excuse me. We'll be trying to determine the nature of the poison, looking around. This is in our initial scene size up and our general impression. We're looking around for paraphernalia, things that might indicate any kind of drug activity, things that might indicate that there is some substance that could be a poison. Also, if you remember, your personal safety is paramount. So if you were to walk into a room and you found multiple people unresponsive, the first thing you would do is back out of that room, determine the cause, and potentially call in a specialized team to deal with a situation like carbon monoxide. If that patient vomits, make sure that you examine the contents for pill fragments. That's important because we want to know how much has digested. If we can narrow down how much of a medication or a substance has been taken, then we can see how far along it's gone and how much of it may have already been ingested into the body. And we're going to document anything unusual that we see. So let's talk about how poisons actually enter into the body. There's 4 routes: inhalation, absorption, ingestion, and injection. And all 4 routes can be life-threatening. And there's examples of each: the inhalation, top left, absorption, injection on the bottom right, and we know that we can ingest pills and substances as well. So for inhaled poisons, first thing we want to do is get them out in fresh air. If there's any, that doesn't mean that, it has to be a room full of toxic gas. If we believe that the patient is overdosed on something as simple as, I should say, been poisoned on something as simple as typewriter cleaner or gasoline, paint fumes, those type of things, we want to move them out in fresh air. They might require supplemental oxygen, but if you do suspect any kind of presence of anything toxic, make sure you contact local fire or hazmat or a specialized team that can come in and deal with that. So some of these patients might have to be deconned by a hazmat team before you actually come in contact with them. Just know that if you do come in contact with them prior to seeing that noting that they have been poisoned, you may have to actually go through a decontamination process as well. But always make sure that we're prepared to use supplemental oxygen and that we're prepared to manage an airway, including suction. And some patients that have used inhaled poisons obviously commit suicide in the vehicle. This is where we mentioned carbon monoxide earlier. Just make sure you're aware of your surroundings. You don't want to walk into anything and become a patient yourself. And these patients can, carbon monoxide, high levels of that. Remember, carbon monoxide binds to hemoglobin much more readily than oxygen does. And so even though we would use our tools, our assessment tools like SpO2 or that type of thing, it may be reading 100%, but that doesn't necessarily mean that it's oxygen that's bound with the hemoglobin. So just because we're at 100%, our patient may not be circulating any viable oxygen at all, and they will lose consciousness and eventually stop breathing. Absorbed poisons or things that patients come into contact on surfaces, they can affect the patient in many ways. So you may have actual irritation to the skin, or maybe a mucous membrane if it was breathed in, or eyes. There could be burns, rashes and lesions, and there could be systemic effects. If you were to come in contact with something that was an anticholinergic, for example, you might have those effects. It doesn't really matter which way the poison enters the body. And contact poisons, they list signs and symptoms, but they're all pretty much cookie cutter. Could be we see liquid or powder on the patient's skin, or burns, or itching, irritation, and redness on the skin, or potential odors associated with a specific substance. And we're going to treat that by obviously avoiding contact ourselves. And we're going to remove that substance from the patient as quickly as possible. Removing all clothing, we're going to flush and wash the skin. Remember that if there's any powder there, we want to make sure we brush that powder off, because we don't know if it's reactive with water or not. And then we're going to flush the area with 15 to 20 minutes with water, and then once again liquid as well. We would flood for about 15 to 20 minutes before washing that area with soap and water. If there's anything in the actual eyes, we would want to irrigate the eyes for a period of time, 15 to 20 minutes as well. And we can use, you can see there in the picture where they've used a nasal cannula along with saline to place that on the bridge of the nose, so it irrigates both eyes simultaneously. And obviously in an industrial setting, you may see chemical burns. Safety showers and eye wash stations and those things may be available. Try to note the location of them, or ask members of whatever organization you're at where those specific things would be, because you can utilize those to treat your patient. You don't necessarily have to treat them solely in your ambulance. And after they've been deconned, we're going to transport them directly to an emergency department for further care. And if you can, every business, every location that has any kind of chemical whatsoever on site should have an MSDS sheet on that specific chemical. So if you know what they've come in contact with, ask for the MSDS information, so that way you can take it with you, and you can alert the hospital and the ER as to exactly what chemical they've come in contact with. So ingested poisonings, obviously big majority there, 80% of poisonings by mouth, and it could be anything from household cleaners to contaminated food, might be plants or ingested drugs. In children, it's typically accidental, more deliberate in adults, but signs and symptoms could include, depending on what the substance is, burns around the mouth, or GI pain, vomiting, could be even cardiac dysrhythmias, could actually cause seizures. So basically what we're going to do with ingested poisonings is we're going to treat the signs and symptoms as they come about. And we do that by managing airways, supporting ventilation and breathing, and supporting circulation through our shock treatment. Another way we might deal with ingested poisonings, and you have a drug card on this, is by administering activated charcoal. Remember, this is a suspension. It would need to be shaked. You'd have to shake it to return it to its original consistency before administering it. And but you would never do this to a patient who could not maintain their own airway. In most cases, you're going to actually have the patient drink this so that it may bind to the whatever the ingested poison is, and not allow it to be absorbed into the bloodstream through the intestinal tract. Injected poisonings, the onset of symptoms would be almost instantaneous. And so this could be anything from people using IV drugs to being stung by an insect. You might see some localized irritation around the site of the injection. And obviously, if it's been injected, it can't be diluted or removed from the body in the field. There would have to be some type of antidote administered to the patient. And it could include signs like weakness, dizziness, but literally there's a huge gamut of them. But obviously what we would want to do is monitor that airway, provide high flow oxygen if needed, make sure that we're prepared to suction if the patient becomes nauseated or begins vomiting. And we're just going to do our standard treatment of ABCs, making sure that we keep the airway patent, support ventilation, support circulation, and if there has been if there's any localized swelling or anything like that, we'd want to remove any kind of rings, watches, bracelets, or whatever before that swelling were to occur. So we know how to size up a scene. We know how to look and say, does the scene appear safe? Do I note any unusual odors? Do I see any medication bottles lying around or any paraphernalia? Do I see alcoholic beverage containers or an excessive amount of such in drug paraphernalia, that type of thing? We already know how to, remember our 5 parts of our scene assessment are scene safety, PPE, how many patients do we have? Is this a mechanism of injury or a nature of illness? And do I need additional resources at this time? And that could be anything from ALS to that hazmat that we've mentioned numerous times. We know how to do our primary assessment again. We get that general impression, and then we go, hey, are you okay? Establishing that level of consciousness. And then we go into our ABCs, determining any life threats and dealing with them specifically as we get to them. And then we make a transport decision. How do we know what the person has been exposed to or what they've taken? And do we know what effects that particular chemical may have on the body? And if so, establish a patient priority. And in most cases, this patient's going to be a rapid transport. And we're going to, even if we've called ALS, probably meet them en route. Also, don't forget, you can call poison control. We know our sample history with our signs, symptoms, allergies, medications, pertinent past medical history. Last oral intake is big in this case because we want to know if they've had anything to eat or drink prior to or after any ingested poison and events leading up to, and that would tell us how the exposure actually happened. And if our patient is unresponsive, we know we've been taught to gather information from family members, bystanders, and so forth. In addition to sample, we'd want to know what that substance was. We've already mentioned that, and how the patient became exposed to it, and how long ago did they become exposed to it. So we'd be able to establish some kind of timeline that we could relay to whoever was definitive care. And then is this a long-term exposure, or is this something that happened instantaneously? And has any bystander performed any intervention, such as if it were a drug overdose, we might administer Narcan because we know that there are family members out there that have known drug users in the family that have prescriptions for things like that. Specific industrial sites might have specific antidotes for specific chemicals that they keep on site, and you would want to know the name not only of give the MSDS information from whatever that is, but also the information for whatever antidote was administered. And once again, we can tag in how much does the patient weigh, because weight, just like when we give drugs in the field for positive reasons, so a lot of those drugs are weight-based because that determines their effect. We would want to know how much the patient weighs, because then maybe we could, calculate how much of an effect it was going to have, the substance was going to have on our patient. We know physical examinations, if there was a injection or whatever, if it was ingested, we'd look for burns in the airway. Injections, we'd look for irritation at the site or whatever. And a lot of this is common sense, but make sure that during our secondary assessment, we want to get a complete set of baseline vital signs. And then on critical patients, we would reassess that every 5 minutes. If you feel like your patient's stable enough to go for every 15 minutes, that's fine. But our reassessment goes all the way back to the very beginning. Remember, we look again for hemorrhage. We check level of consciousness to make sure there's been no change in our patient's mentation, our ABCs, and so forth, and see if any interventions that we have actually administered are having any effect. So you want to contact medical control in the poison center. Please note that you'll need to keep there should be in the back of an ambulance, there's probably a poison control number on the wall. However, you can contact medical control, or you can contact central dispatch, and they'll typically be able to give you that number. And that's going to be 800-222-1222 if you were to want to store it in your phone. It's not only good for while we're on duty or in a pre-hospital setting, but it's a good contact number to have around the house, because we never know what could happen in our own lives. And we're going to communicate and document, right? Report as much information as we can get. And that, once again, there's that MSDS sheet we'd want to bring to the hospital with us. When we're caring for patients, we've already mentioned scene safety, removing tablets or fragments from the patient's mouth by suction, wash or brush any poison from the skin and irrigate, I apologize. Do that X, which is hemorrhage, level of consciousness, airway, breathing, and circulation, provide oxygen, or we might even have to assist in ventilations if our patient had increased or decreased respirations or an inadequate tidal volume even. Treat for shock, lie them flat, wrap them up, elevate their feet if necessary, and some systems will allow you to give the charcoal by mouth. And what charcoal does is it actually binds to specific toxins, and then it's carried out of the body in the stool. And some of them have a substance called sorbitol. It's a sugar-based laxative, so it kind of pushes all that through a little bit faster and doesn't let it sit in the the intestinal tract. However, we wouldn't want to give charcoal to anyone who's ingested anything let's just say caustic that may burn on the way back up if it were to cause vomiting, because charcoal is pretty gross stuff and your patient very well may vomit. And you remember that patients with decreased levels of consciousness cannot control their own airway. So 50 grams is your typical dose. Remember, shake it up first. The usual dose, if you're going to be doing it weight-based for an adult or child, is still going to be 1 gram per kilogram of body weight. And we know that a kilogram is 2.2 pounds. So you'd have to make that conversion. But before you give patient charcoal, you'd have to obtain approval for medical control in certain protocols. That's not the case in North Carolina, but you would have to shake the bottle vigorously, and the patient needs to drink it. You can't pour it down their airway, and you're not putting any tubes down their esophagus into their stomach or whatnot. They would have to voluntarily drink it, and if they refuse that, then you would have to document that refusal, and that might even cause you to increase your how rapid you're transporting your patient. The side effects of having charcoal, even though there is a laxative involved in a lot of brands, are going to be black stool. The patient may become constipated, and remember that if a patient's ingested a poison that actually causes nausea, they may vomit after that charcoal, and the dose may have to be repeated. You're not going to overdose someone typically on charcoal if you have to repeat that dose. So we'll talk a little bit about specific poisons. A person who routinely misuses a substance might start getting build up or start developing a tolerance for a substance. A person obviously with an addiction has an overwhelming desire to continue using a substance. We know that methamphetamines and cocaine and heroin and things actually change your brain chemistry in the way your serotonin and dopamine interact, and can actually you can use heroin, you can still have cravings for heroin a year or more out. Methamphetamines 2 or more years out, where they actually change the chemistry of your brain. So it's not that so much physical dependency on it like a withdrawal symptom. It's just simply your brain knows what that substance does and it wants it. That's why we say, well, so and so drug user had a relapse, or he slipped off the wagon or whatnot, but it wasn't because they've just made this conscious decision that, well, I've gotten over whatever drug problem I have, and then it's no. Or remember that brain chemistry can be changed for a long period of time after using. And it's important to, once again, make sure we're aware of our scene safety and take our standard precautions. Known drug abusers have fairly high incidence of undiagnosed infections. They got HIV, hepatitis, a lot of needle sharing things happening there. And so expect the unexpected, and remember that the drug user is not the drug can pose the greatest threat. So if the drug user themselves can become combative or whatnot and actually causes physical harm. So alcohol is a big one out there. A few slides on this. There are going to be a lot of alcohol related calls that you're going to go on. And we know that alcohol can damage the liver, whether it's from chronic overuse a little bit every day, or patients who binge drink large amounts in a short period of time. Binge drinking can actually be more damaging than chronic use, because depending on the frequency of the binging, you're talking about excessive amounts of alcohol entering the body in a short period of time, and that can cause lots of problems. And we know that alcohol is a depressant. It decreases activity and excitement. It can induce sleep, or we can pass out. It dulls the senses of awareness, slows reflexes, might actually slow reaction time. Once again, remember, people that drink and drive have a slower reaction time. But people can also become aggressive, or exhibit inappropriate behavior, things they wouldn't normally say or do. They can have a lack of coordination, or it could cause problems with patients who are diabetics, because alcohol definitely affects blood sugar. Alcohol increases the effects of other drugs. You note on a lot of drugs you see do not take with alcohol, or alcohol may intensify effects. If a patient has any kind of sign and symptom of central nervous system depression, remember that we want to airway, breathing, circulation. They may vomit, be ready to suction, and some patients with severe alcohol poisoning can experience hallucinations, or even delirium tremens, or DTs, as they withdraw. Withdrawal symptoms, or the DTs, are signs and symptoms that go along with that are they can be agitated, fever, sweating, combative. They may have shakes or tremors. They may have episodes or long-term periods of confusion or disorientation, might even hallucinate, and all the way to seizures. And that's going to be based on what their typical blood alcohol level is and what it comes down to. There have been cases where we know that 0.08 is considered in the state of North Carolina as legally intoxicated, and anyone who is 0.12 or higher is considered extremely inebriated. We do know that also that, if you get up around 0.4, you could be considered legally dead, because literally can shut your body down. But there have been situations where people were detoxing, and when their blood alcohol levels got down to things like 0.25 or whatever, they actually began having seizures and going through with severe withdrawal symptoms because of their chronic abuse. So even though you might not know your patient specifically or whatnot, through your history taking, try to gather the information as to how much the patient ingests on a daily basis and what that might be. We know that opioids are a huge crisis. They're typically prescribed by doctors as a pain reliever. They're not a pain blocker. They act on opioid receptor sites in your brain to instill a sense of euphoria, which makes you kind of not care that you hurt. All opiates come from poppy seeds, and you might think of things like codeine, morphine, fentanyl, oxy. Here's a list of some common ones: Stadol, Dilaudid, hydrocodone or Vicodin, or Percocet, and things that we are familiar with. And opiates are some of the most commonly abused drugs in the United States, because literally they've been given out like candy for the last 20 years because, oh, my arm always hurts. Well, here, have an opiate painkiller, and people become physically dependent on them for just even from taking their regular appropriate prescription. As they build a tolerance, then obviously they want more of that drug, and they can use more than their normal prescription would allow. There are also stipulations on opiate prescriptions that only allow them to be filled like every 30 days. So you can't like run out in 2 weeks and then, go get another script. They're going to have to wait for their full 30 days. And if they're a long time user and they've started using more than they normally would on a daily basis, by the end of the month, they may have run out. And these are people you might see turn to alternative means of acquiring medications that might not be specific. They might just be getting some kind of street opiate, or maybe, moving on to something like heroin. So they do develop a tolerance quickly. You'll see long-term heroin users specifically, if they'll actually go to rehab just to dry out, because when they come out, then they have no intention of never using again. They go through a program, a 28-day program in some cases, that completely and totally eliminates their drug from their system. So when they use again, they get that original high back, because obviously as the tolerance builds up, it takes more and more and more of the drug, and they don't get that that buzz that they got to begin with, and they're always kind of chasing that. They can have seizures, not really common though. They're typically going to be unresponsive or very sedated. They'll have pinpoint pupils because remember, these are sedatives. They're the opposite of the sympathetic nervous system. These are things that activate on our parasympathetic. So we've got the pinpoint pupils, decreased respirations, or potentially no respirations. And we reverse these effects by using Narcan or naloxone. And our dose for that is typically going to be, and you'll see in a textbook, it'll say 0.4 to 2 milligrams. And you'll be giving that intranasally using a MAD device or a pre-filled Narcan nasal spray, depending on what your agency carries. Remember that in the pre-hospital setting, we try to administer that in increments and not just all at once. Your street dose, and remember I said textbook is 0.4 to 2, but your street dose, we just say we give 2 milligrams of Narcan. But that doesn't mean you have to give the entire 2 at one time. You can give 1 milligram up one nostril and wait 30 to 60 seconds to see if there's any effect, and then give the other milligram in the other nostril. The key is though, you want to remember that we don't bypass our ABCs. We don't avoid or forget to bag our patient or manage that airway in order to give Narcan, even if we know what that problem is, because we want to make sure that we maintain our airway, breathing, circulation. And once we get that maintained, we can administer Narcan in order to hopefully help our patient recover. And remember, once again, that there are lay persons out there that are allowed to administer Narcan, and you'll see law enforcement and fire carrying Narcan in their units in a lot of cases because they'll have protocols written for such. We're going to zoom through these barbiturates and benzos. They alter your level of consciousness. They may appear intoxicated, but once again, they can cause that respiratory depression or whatnot. Some hypnotics are used as date rape drugs or knockout drugs or whatnot. They're dissolved in water. They could be injected. And our treatment's going to be simply the same as everything else: airway, breathing, and circulation. Inhalants, things that are inhaled as a general rule, you're going to find paint thinners and paint. Gold paint, for whatever reason, is supposed to be the most potent, but they're going to be inhaling acetone and toluene and xylene and hexane and all these things that are found in these different chemicals. You'll see people huffing out of gas tanks, and this is commonly done by teenagers or long-term drug abusers that just need to get a fix to get them by, if you will. But we know that abused inhalants come along with issues like airway burns or whatnot. And the biggest thing we already mentioned was that we remove them from the environment, trying to get them into some fresh air, and potentially have to manage that airway and administer oxygen. Hydrogen sulfide is highly toxic. It's colorless. It's a flammable gas and has a distinct rotten egg odor. So like we always hear about sulfur. It affects all the organs, but it has its biggest impact on the central nervous system and on the lungs. People do use it to commit suicide. And if you ever expect the possibility of a toxic gas, remember to make sure that a team comes in. If you approach an enclosed vehicle with an unconscious patient inside, make sure that you look for signs like containers or buckets or pots, because this is chemical suicide is definitely a thing that has become more popular over the last few years. Signs and symptoms associated with hydrogen sulfide are going to be nausea and vomiting, confusion, and difficulty breathing. But our big, obviously, it can progress to loss of consciousness and cardiac arrest. Once the patient's been decontaminated, management is largely supportive. There's nothing you can do to actually reverse the effects of hydrogen sulfide. Sympathomimetics, we said, mimic the sympathetic nervous system. And here's a list that you can read on your own, including everything from cocaine to MDMA, speed, and so forth, where that increase the processes of the body just like adrenaline would. You get that excited state, you get the high blood pressure, the increased heart rate, the dilated pupils. Amphetamines, there are a lot of there are a lot of prescription medications that are used in the same way. Obviously people don't go get a prescription for cocaine, but they do get prescriptions for things like Adderall for ADHD or whatnot. Designer drugs like MDMA, which is ecstasy or Molly, for anyone who didn't know. These drugs can be injected, but they're commonly taken by mouth in pill form. And they can improve, and it's a hypersensitivity of touch, increased body temperature, whatever. Cocaine's out there still, even though it's not as popular as I guess it was a few years ago, but it can be absorbed, it can be snorted, it can be smoked. Smoked crack is definitely the most potent. One of the things you have to worry about there is not only the effect of the cocaine on the body, but also the effect on the lungs and whatever it may have been cut with or mixed with. You have to kind of keep in the back of your mind that other substance may cause an issue too. And anytime there's an overdose, this is a true emergency. There's high risk of dysrhythmias and chest pain, patient having strokes from high blood pressure and seizures. Never leave the patient unattended, but maintain the airway, breathing, circulation, and rapid transport. So bath salts. It's an emerging class. It's kind of like Molly or ecstasy. The thing is that with bath salts, the effects can last not just a few hours, but as long as 2 days or 48 hours. And a lot of these drugs, bath salts, are snorted. You can have a lot of the like meth side effects, like the teeth grinding and appetite loss or twitching, involuntary movements, but you can also have the headache, elevated heart rate, and hallucination. You would always consider ALS assistance for this, but make sure to try to keep the patient calm and transport. And if they become combative, deal with them appropriately. But if they at any point become altered, remember to manage airway, breathing, and circulation. Marijuana is used all over the world. True THC is a chemical in the marijuana plant, and it really it's a sedative. It produces drowsiness, relaxation. Some people say it makes them clear-headed, or more creative. It impairs short-term memory, and you can't really do a lot of complex thinking, even though a lot of times people who use marijuana feel like they are having the deepest thoughts of their life. But continued use could progress to depression and confusion. Marijuana is not physically dependent, but it can become psychologically dependent. With very high doses, patients can hallucinate or become anxious and paranoid due to the psychotropic effects of the drug. But it's often used to get other drugs into the body. You might see it mixed with hash or fentanyl or some things, PCP, other really hard drugs. And sometimes you have patients out there who just literally went and bought marijuana thinking that they were just buying marijuana, but it was laced with something else. And so you get called out to a severe reaction to such. And we know that a lot of states have actually legalized marijuana recreationally, and that comes in lots of different forms. Edibles that are infused with marijuana, it can actually lead to cannabinoid hyperemesis syndrome, which is literally like extreme nausea and vomiting, and the only way to combat it is with a hot shower or soaking in a hot bath for a period of time. And obviously we don't carry hot baths, and we don't let patients soak in the back of an ambulance. So that would lead us over to managing an airway and continuing to suction if needed. And then there's synthetic marijuana, or also known as spice. And this is herbal incense and smoking blends, and their effects resemble THC, maybe not exactly, maybe not with the exact psychotropic effects, the side effect of hunger and things. But the downside is that a lot of times they can be more powerful than standard marijuana or regular THC. And because we don't know exactly what's in them, the effects may be unpredictable. And that could be just anything from them being happy or to them completely losing consciousness and no longer breathing. Hallucinogens, they alter a person's perception, make patients see things. People do this for fun. One of the big ones out there now that's being pushed on the medical side is ketamine. We know that we have LSD and PCP that have been around for a long time. We also have salvia, which is a plant that can grow in. It's not illegal. It can be like you might actually have one in your shrub bed outside. But these hallucinogens, they cause hallucinations. They intensify the vision and hearing. They basically separate people from their reality. But the possible emergency is someone having a bad trip or having the side effects of high blood pressure, tachycardia, the anxiety. They could be paranoid and become combative. So you're, once again, scene safety is going to be paramount. You're always going to be calm and professional, provide emotional support. Don't buy into hallucinations. Never tell someone, oh yeah, I see the pink elephant too, or whatever. You just tell them, no, I'm not saying it's not real, but I'm unable to see it right now. We try not to restrain them if at all possible, unless they're actually a danger to themselves or others. But we're going to watch them really carefully, request ALS, and be sure to monitor those ABCs and provide supportive care. Anticholinergic agents that we've already talked about. They block the parasympathetic nerve or parasympathetic response, which slows everything down. So if they're blocking the systems in our body that slow things down, apparently there's a saying that I've never heard in my life out there other than in the PowerPoints for the last few textbooks, but it's hot as a hare, blind as a bat, dry as a bone, red as a beet, and mad as a hatter. Do with that what you will or whatnot. But common drugs include people that take atropine or overdose on Benadryl. Amitrip is a drug that you might find patients out there that are prescribed that they overuse. And even some tricyclic antidepressants can have some significant anticholinergic effects if used inappropriately. So once again, airway, transport immediately, and call ALS. Cholinergic agents are obviously the opposite of anticholinergic agents, and they overstimulate the normal functions that are controlled by parasympathetic. And we know parasympathetic slows everything down, so they overly slow things down. These can be anything from nerve gases that are designed for chemical warfare to people out on farm sites being exposed to organophosphates that are used as pesticides. One of the mnemonics we use is dumbbells. We also mentioned sludge earlier, but the dumbbells is diarrhea, urination, meiosis, which once again we remember is the constriction of the pupils, bradycardia, maybe a bronchospasm, impairing our patient's ability to get a good tidal volume, emesis, lacrimation, which are tears, and seizures, and sweating also accompany that. And there's our sludge M mnemonic one more time. You can review. And the big thing is you want to make sure you don't get exposed yourself, right? Decontamination might take priority over immediate transport. Wash them down or eliminate the continued exposure to the drug. And this will, in most cases, will require a hazmat team to provide true decontamination, because those aren't things that we carry on a typical ambulance. But after the patient and ourselves have been decontaminated, we might have to suction and provide airway support. We also may be able to use an antidote kit if you have one on your ambulance, and that is the Duodote auto injector. It does have pralidoxime and atropine in it. Atropine is not a drug that can be given by an EMT, as in drawn up and given voluntarily, but in an auto injector in Duodote, it is absolutely acceptable. The old premise was that there were typically multiple doses per person on an ambulance. So there were multiple doses for both EMS technicians and the patient as well. And there's some miscellaneous drugs. There's a list of everything from calcium channel blockers that can cause arrhythmias to beta blockers that can slow our heart rate, antidepressants that can cause all kinds of side effects, and accidental or intentional overdose with cardiac medications has become common. Someone wants to commit suicide, they take a lot of beta blockers. Beta blockers are given to slow heart rate for blood pressure and for patients who suffer from atrial fibrillation. And an overdose of this would obviously slow the heart rate to the point where our patient will become unresponsive and then possibly go into cardiac arrest if not treated immediately. And obviously the signs and symptoms are going to depend on what medication is ingested. You're going to contact poison control. If someone overdoses on aspirin, they may be nauseous, they may vomit, they may start hyperventilating, they may develop a ringing in the ears. That is just a clue to an aspirin overdose. Nobody ever died from ringing in their ears. And patients that have this problem can be anxious or even confused. They might have a high body temperature or hyperthermia. They are always in danger of having seizures, and you might see increased respiratory rate as well. People can also overdose on acetaminophen or Tylenol. It's common if your patient overdoses on acetaminophen just in order to harm themselves. Well, they pretty much won. There's not a lot you can do about it once it's absorbed into the body. They may not pass away immediately. It's going to take weeks or months or potentially even years, but their liver will shut down and they're going to suffer from liver failure. The sad part is that there's not really anything that can be done about it, because if this is because of self-harm, they wouldn't be able to make a transplant list in order to get a new liver. Food poisoning is actually pretty common. Everybody's eaten something at some point that made them sick. Typically, there's an organism in the food that produces toxins that make us sick. There's a list of common causes of food poison. I'm definitely not reading that entire list. You can read that and look up each and every one of them if you like. We know that we're familiar with salmonella because everybody says you shouldn't touch raw chicken. And salmonellosis is that exposure to salmonella, and it's characterized. We have the severe GI symptoms, the nausea, the vomiting, the cramping, and diarrhea for up to 72 hours. So remember that with that type of loss of fluid, a patient could go into shock, hypovolemic shock from that loss of fluid over several days without being able to keep a normal fluid intake. And obviously foods that are left unrefrigerated can cause more issues than refrigerated foods. And botulism. Botulism is deadly. It's hard to differentiate the types of poisonings in the field, but if someone says they ate canned food that may have been improperly preserved, then they could have blurred vision, weakness, difficulty breathing, or whatever, and these symptoms can develop within the first 24 hours or as long as 4 days later. And botulism is a life-threatening emergency. So manage airways, treat breathing, support circulation. And plant poisonings, finally, right there, it's a list of all the plants that you might come in contact with, or your patient might have come in contact with. Everything from poison ivy to mistletoe to a castor bean, which castor oil comes from, but also the terrorist weapon ricin is developed from a castor plant. So all these, depending on the plant, will determine what type of symptom you're going to have. But you're going to want to make sure, once again, airway, breathing, circulation, get some vital signs, notify poison control, and if you can, take the plant to the emergency department. Just make sure that if you don't know what kind of plant it is that they've been exposed to, that you don't get yourself exposed as well. And there are some pictures of some normal things that you might see, from mistletoe to castor beans, nightshade, even a rhododendron there that someone might have out in a flower bed. And along with the poison ivy and poison oak, and all the way over to poison sumac there in the bottom right-hand corner. And that's going to be the end of the toxicology PowerPoint. But like I said, please review, go back through the slide notes from the PowerPoint presentation as it is put into your Blackboard shell.